Hello, everybody. Welcome to Two Doulas and a Midwife. I'm here again with Danielle and Sharon, and we're just going to have a wonderful conversation about all things pregnancy and birth. Today, we're going to focus a bit on the third trimester, what to expect, blood tests, emotions, preparing yourself, and we're just going to have our usual wonderful enlivened conversation about it. And we're going to kick off with an introduction from Danielle and Sharon. I'm Lisa. I'm in Johannesburg, South Africa. Two doulas and a midwife. I'm a doula. And I just absolutely love these conversations we have. And I'll hand over to Danielle. She can introduce herself and Sharon, and then you can kick it off, Sharon.
Thanks so much, Lisa. Always wonderful to be with you ladies. So I am the other half of the doula team, Two Doulas and a Midwife, also based in Johannesburg. And this is now a very exciting part of our pregnancy journey, the third trimester, the home stretch, as we call it, and looking forward to hearing Sharon's pearls of wisdom.
Goodness me, how do you follow that one? Thank you, Two Doulas. Is I the midwife? Yes, it's such a milestone, the 36-week mark, for so many reasons. And if we start with 35 weeks, which is just the end of her second trimester, she's going to start noticing backache and period pains and encouraging or stretching sensations in the lower girdle part of her body. And this is because her ligaments are going to start softening. And that's all the connectors of the bones of her pelvis. And all the cartilages around those supports are going to start softening as well. And this is so that her pelvis can give way and enable the baby to descend into the pelvis. And how exciting is that? At the same time, her uterus is changing shape. So until 36 weeks, her uterus was round, and it was a protective mechanism in order to keep the baby away from descending without permission or getting too heavy in the lower part of her body. And so now the uterus changes into a pear shape, and the lower segment is formed, and therefore the baby can start drilling from 36 weeks into the pelvis. So it's a wonderful time for her to be aware that her dates are correct, in that if this were to start happening before 36 weeks, then she wants to just check her dates and see that perhaps the baby isn't earlier, or perhaps therefore coming sooner than anticipated. And also to consider if the baby's not doing that right now and is only happening 37, 38 weeks, then perhaps her dates are not wrong, but out on the other side, and perhaps this baby's not coming for some time. I also get my mums to check their cervix because it's their body, first of all. I don't like people having to tell them what's happening in their body. You know, you live in your body and you have the right to know what's going on. And the cervix at 36 weeks should be closed and tight and very difficult to find. And from 37, 38 weeks, it's going to start softening and changing, and lots of changes taking place. So it's, for many South African mums, a time when she's going to stop work. And I like my mums to stop work latest 36 weeks, because then it gives them 2 weeks of preparation time, of transition time, to not be the working mum solely, but to be the in confusion mum in waiting mum in preparation, because babies are full term at 38 weeks and are welcome to be born at 38 weeks. And what I tell them, of course, is that you don't want to go into labor at work, because that can be embarrassing. And also because it means that if you go into labor at work, you've had no time to be the in-between person, that you got up one morning with work mode on the mind, got your work gear on, sat in your work traffic, got to work, did your normal thing, and came home a mum with a baby in your arms, which I think is totally confusing. And research shows us that that is one of the things that can lead to postnatal depression, is not having time for thought and focus. And so it's a wonderful opportunity that between 36 and 38 weeks for her to get her journal out and to ask herself the difficult questions about what am I preparing for? How am I preparing for that? Am I preparing for a baby? Am I preparing for a birth? Am I preparing for pushing a baby out of my body? Am I preparing for possible complications? Am I preparing for surgery? What am I preparing for? And again, one of the challenges, I think, is that a mistake that we make in the modern world is that we only focus on the birth. How are you getting that baby out of your body? And we don't look at how we're recovering from that, and how do we move on from that moment together as a team, as a family, for not only recovery physically from a pregnancy, not from, many women are having a surgical birth, but from being pregnant for 9 months, from being not yourself in so many interesting ways for 9 months, and then experiencing labor and birth, and then you've got to get it all together and be what? Who are you then? How do you recognize yourself? And of course, for you to prepare each other. It's not one person on this journey and one person who's watching. It is hopefully two people on this journey, and at the end of this journey, you will come out as something entirely different to who you were when you entered the journey. And that's like a butterfly, isn't it? Go in as a caterpillar and you come out entirely different. What were you going to say, Danielle?
It's with my parents. I actually give them a postpartum checklist, and I ask them to reflect on what it's going to look like. What is our family going to look like after birth? Who's going to be doing the cooking? Who's going to be doing, the nighttime shifts? Are you breastfeeding? And I make them think about all those things, because it is so important. We do only focus on the birth. So many parents, and you say to them, so, are you going to have help at home? Are you not? Are you doing this? And they're like, well, we haven't thought about that. We haven't thought about what's going to happen once we take baby home. And it is very important. But Sharon, I want to come back to that self-examination that you spoke about at the beginning of this, is that cervical examination. How would a woman go about doing that and checking that herself? Because, it is wonderful, and we told not to do it. Generally it's.
But why
it's not exactly. Why shouldn't we do it?
Contraceptive device, you would be in there checking the cervix. If you were family planning naturally, you would be checking your own mucus. It's ridiculous that you can check your own breasts and not check your own cervix. So,
and a lot of people don't think about that.
Yeah, exactly. Or that we don't teach women to be in control of their entire bodies. And so it's important, if you are checking your own cervix, not to try lying on your back, because then everything drops posteriorly and you're not going to be able to reach or find anything. So if you were exploring your own cervix, the vagina is a blind-ended tunnel. And if you are squatting, I would suggest with the wall behind you so you don't fall over into yourself. Or if you've cleaned the loo and you've washed your hands, obviously, and you're squatting on the loo and leaning forward, that's the easiest way to find the cervix. And then so many people will say, well, my fingers aren't long enough. But if that were the case, we would have to measure doctors' hands before they decided to become gynecologists or obstetricians, wouldn't we? We'd have to check the length of your fingers to see, well, are you going to be able to achieve this aim, this goal? So yeah, her fingers are perfectly long enough. Not those artificial nails though, not
Yes.
the best plan.
Yes.
I think a lot of doctors are afraid of having their clients introduce infection, and that's why it's not encouraged. That's why women aren't encouraged to to examine themselves. But I think if you've this, as you say, this is your body. And getting to know yourself, it can be a wonderful experience to to see where am I holding. Oh, that's what it feels like, and that's what's holding my baby in. And that's I think to educate yourself about your body, and obviously doing it in the right way. There's no right or wrong in terms of giving yourself a feel and seeing what it's all about.
Exactly. Or to share it as a couple. There's all sorts of things go into a woman's body. If you're going to get an infection, you would have to scrub your partner's member before you were ever to have sex, would you not? So infection is far more likely to come from bad hygiene, in that you're not wiping yourself properly after going to the loo. And of course, then we're talking about nappy changing and little girls and all that side of things as well. But I think to give women the right, to encourage women to know their bodies, is part of taking autonomy over your health. And who has the right over your body? If not you, who would you give it to? So all my dads do perineal massage from 28 weeks. And so on one hand, that expands their relationship and their level of communication, because it's a very vulnerable thing for a woman to open her body and to hand it over even to her lover. It's a vulnerable time, and yet to feel that you're in the best hands, because he is your lover and he is the one who cherishes you and respects you the most, and is there to protect the body from any harm through the birth. That if women have done perineal massage for centuries, and it's an Ayurvedic method that has been done for a very long time, and so we have just opened it up on a more modern way. And I think psychologically it helps for her to know that from 28 weeks, we're taking time, we're going very slowly. She's aware of the changes that take place. And one of the main ones is at 36 weeks, when things start to soften and relax, that she can feel that together they are a team, and that together they are protecting her body. And after the birth, it's usually the dad who's hanging over my shoulder to check, how did I do? How was my work? Is the perineum fine? And that feeling of pride in his contribution to her protection. We're looking at the traditional role of the male in the family. And one of those traditional roles is protection and defense. And this is the modern way of protection and defense against harm in her body. That there is no reason for a woman to come to harm. It wouldn't make sense. That birth can harm her in such a negative way, in such a permanent way. And so if we are working proactively, psychologically, she knows when the time comes for her to push like a lunatic to get that baby out of her body, she can do it confidently, knowing that this might hurt and there might be a ring of fire, but that she knows the difference in what her perineum felt like at the start of their communion and what it felt like at the end at 38 weeks. Excuse me. And then she can push with confidence. The midwife is going to take care of that perineum from her end, in that we're going to use water for the labor that keeps the muscle soft and supple, that she's going to be in a positive forward direction to give birth and not on her back, that she's going to be in a tripod position, that she's going to have her hand available on her baby's head as she's pushing that baby forward into her own hand. And the midwife is likely to I use homeopathics. I use homeopathic ointment. I use homeopathic remedies. I use hot water on a flannel face cloth. I use aromatherapy in order to keep that muscle soft and relaxed. And then because we've had a relationship for some time through the pregnancy, there is that trust that comes into play where I'm telling her, give me a big push, give me a little push, don't push now, just breathe. And she can feel when she's pushing well, she can feel her baby descending through her body, and she can feel her hand being filled with her baby's head. And if she's not pushing because she's pushing into her face and not into her bum, then she can feel that too. And she doesn't need somebody then bullying her at the end of a bed, push, 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 like we see in the movies. But that she is again part of that team and part of her birthing herself as a mother, her birthing her baby into her arms, not just the skin to skin afterwards. Now it's convenient for me to give you the baby, but for her to push that baby from her body into her hands is just the
Beautiful.
best.
But now going
Yeah.
back to the perineum, sorry. What oil would you use to massage the perineum? Coconut oil, olive oil?
So we use the organic coconut oil because coconut is an antifungal. So if she has any sign of thrush that she is not attending to medically, which of course is always a good idea because infection is the most common reason for women to go into labor prematurely. And so, of course, we were trying to avoid infection, and, teaching regular hygiene is the best way to do that. But if she has any kind of sensitivity in the perineum, in the vagina, then coconut oil, organic coconut oil, and warming it in a bain-marie. So putting a dollop into a small bowl and putting that small bowl into a larger bowl of boiling water or hot water so that it will soften and melt gently and no burns are going to take place from either partner, then that's a good thing. And then also at 36 weeks is when she would have her 36-week streptococcus swab. So the interesting thing about Strep B is that you have to, in South Africa, ask for it because it's not routinely offered. And if women are doing their research on the Google machine, they will see that very often in America, it's talked about frequently because it is routinely checked in America. And so we have our first moment of confusion. Why is it offered there and it's not offered here? And it's offered there as part and parcel of their care. Here, somebody has to pay for it, is the first thing. Secondly, the interesting thing about streptococcus is that if you are a carrier of streptococcus, it means it's just part of your microbiome. If it's part of your microbiome, it's not going to attack you. So you can have streptococcus B, which is a bacteria, living in your body without causing you any harm or any distress your entire life. But if you're having a vaginal birth and your baby is going to be born vaginally, then the baby can be seeded in a negative way from the streptococcus and be born perfectly healthy and well, but can also crash medically within hours, and become severely ill with either streptococcus pneumonia, encephalitis, meningitis. And because streptococcus can pass the placental barrier, babies can even be affected by streptococcus intrauterine. And so we talk to mums about their choices when we're looking at the antenatal tests that we offer right at the beginning of the pregnancy. I tell them at the beginning of the pregnancy that this is a test that is offered at 36 weeks. You have to ask for it. So go away and explore it and research it. And so we can discuss it along the way as to what would she like to do. The thing again about testing for streptococcus is because it is part of your microbiome, it's a bit of a hit and miss test, in that if that swab is inserted just at the point when the streptococcus happen to be passing, then we can determine that you are a carrier of streptococcus B, and therefore we can offer you an antibiotic in the labor to protect the baby from being seeded with the streptococcus. However, if the streptococcus is still part of your microbiome, but didn't happen to be passing as the swab was inserted, then we're not going to know that you are a carrier of streptococcus, and you will not therefore be offered an antibiotic cover for labor. And so babies can still therefore be affected by streptococcus either in utero or afterwards. Even though the swab was negative, the mum could still be a carrier and the baby could still be affected.
So how do you get around that then?
Well, you can't. It's like any other test. It's a test. Either have the test, and if you are determined to be a carrier of streptococcus, then you can have an antibiotic cover, or don't have the test. And I think that there is nobody's going to observe a baby more closely after a birth than the parents.
Does the baby get, can you request the baby to be tested as well?
You can do. Normally, of course, if a baby is suspected to have any kind of pneumonia, it's streptococcus that they're looking for first. It is the
Yes, okay. Okay.
Yeah. Yeah.
So that
So
test,
signs of illness.
yes.
You know, premature babies who are in the special care unit are going to be routinely checked.
Okay.
Yeah.
Because that can be quite a daunting subject for moms. You know, do I test, don't I test? What is your suggestion?
Because, you know, any conversation you're going to have with a pregnant mum, that's such a wonderful point that you're making, can be daunting, can't it? You know, should I offer you any kind of antenatal routine test? Should we have a scan even? Because that can be daunting. Most women, of course, think you're going to have a scan so you can see the baby waving to you. But, you know, that's not the purpose of the scan. And the person who is conducting the scan is not looking to see that the baby is fully healthy. We're looking to see, is there anything that we need to alert this couple too regarding the health of this baby. So any kind of antenatal screening that you're going to have has a possible scary outcome. You know, once you are parents, life can have scary outcomes, can't it? What if my child is rubbish at maths? What if they need special somethings, or, you know, extra lessons, or, you know, the whole world is a scary place. So wouldn't it be wonderful if we all planned pregnancies with that in mind? You know, what if we had all those conversations about what if my child is not going to be the lawyer that I would like, but wants to be a busker or a, I don't know, a fairy or
Yeah.
And I think that brings us
for all of us,
to
a
how
unicorn.
much of a psychological thing pregnancy is, as well as, you know, the physical. You know that you know that it's not just, you know, your body does its thing where you know, once you're pregnant, the baby's gonna come out one way or the other, and it's about how you go about using that time that you have. Most of us are very lucky to have a good 9 months in which to prepare, and some of us even before, you know, when we're you know, going through fertility issues, or we're looking very carefully at tracking our bodies. And so it could be, you know, a long time that we are, you know, focusing on the creation of this little person. And although some moms may only land up discovering that they're pregnant quite later into their pregnancies, but I just wanted to touch on what Sharon was saying about, you know, the dad's involvement. And I think, you know, I always say this, and, you know, that, you know, as much as you can involve your partner and get him familiar with your body as well, so that it's not just this foreign thing that is happening to his partner. And the wonderful thing about things like perineal massage, and, you know, it's that intimacy between the couple, and that is what is going to, that when that mom is finally at that stage where she needs to push her baby out, the more comfortable she feels with the people in the room, the more her labor is going to progress. And I've seen the difference where, you know, the dads are so hands-on in the labor room, whereas some dads may be sitting in a chair in the corner on their cell phones. And I've seen the differences in how the moms progress. And so, you know, if you've got these concerns about your pregnancy, and it can be stressful, the streptococcus and all these things. And I think if we, you know, as Sharon was saying, it can go from, you know, am I rhesus negative to will my child be rubbish at maths? You know, if we really took everything too much to heart, we may not even have children. And I think it's so important.
And that's such an important point, isn't it? Because we have to look at the purpose of information. I see the role of the midwife as the educator. And sometimes information can be difficult to absorb. But should we therefore not tell couples, families, what they need to know? Surely information, if I'm told what the outcome might be, I'm going to be armed and ready, even if it means that I've given it some thought as to how best to manage it. We're looking at screening for conditions like Down syndrome. There are those mums who want to have the screening, not because they don't want to have a baby with Down syndrome, but because they need to prepare the family for the fact that this is a child with special needs. And therefore, I need to find where are the best schools, what resources do I have available to me in this area? Do I need to move to find the best resources for this child and their needs. So I believe that information is power. And yes, the modern generation does get all freaked out about being given information. But, if you're going to be a parent, you need to have information.
Because it's never going to stop. After you've been pregnant, it's never going to stop. You're going to want to know everything possible to help your child, to grow, to learn. So why not start right at the beginning?
Yeah.
So now let's take a typical healthy pregnancy. What are we looking at in the third trimester with regards to, we've covered the streptococcus, but what else is looked at in that last trimester? What other tests are done? Does your mom need to go and have another scan? Does she need to see her gynae before she comes back to the midwife? How does it look?
So yes, 36 weeks is when she is seeing her obstetrician. So normally when you're working with a midwife, she will see her obstetrician either at the very beginning, she'll see the obstetrician again at 28 weeks, and she will see the obstetrician at 36 weeks. And this is because, as I like to explain to them, the obstetrician is going to be the person who is invited into the birth if there are complications. The obstetrician is not there if there are no complications. But if you can imagine, if you're having a complication or if your labor is becoming complicated, then it's scary. There is a certain amount of fear and worry for your baby. And so it's going to help you enormously to know that the person who's coming to manage their complication is somebody who's familiar to you, first of all. You have met them in a time of relaxation. You've had a good discussion with them about your birth plan. And your birth plan, my mums do 2 documents. One is a birth plan where they're looking at possible complications and how do they feel about drugs to manage pain after an invasion of some kind, such as a cesarean section, what drugs are available, how the cesarean section might be performed. Are they going to be encouraged to bring their music into the theatre? What is the difference between an elective cesarean section and an emergency cesarean section from the surgical point of view? Can we do it possibly if the membranes are still intact, with the membrane still intact? Can we still have delayed cord clamping if you're having a cesarean section? Will you still have skin to skin? Will the baby go to the pediatrician first? And all the aspects of under what circumstances will the baby go to the pediatrician first? Or will the baby be passed to the pediatrician and then brought directly to the mother, hopefully? Will she be sedated during a cesarean section? Or will she be encouraged still to use her breathing and her relaxation techniques? Because it is the emotional aspect of fear where she hasn't explored that possibility that can lead an anesthetist who thinks that he's giving her the best treatment, the best care, to sedate her. And sometimes, therefore, she's so sedated, she misses the event. And so to discuss those aspects of the human side of this birth under medical conditions is a wonderful opportunity at 36 weeks for her to discuss that with her obstetrician. And also from a normal perspective, 36 weeks through that scan, he's able to have a good look at the placenta, because first-time mums usually go beyond their dates. Term plus 10 is the most common day for a first-time mum to give birth. And so we want to know that there's still plenty of life in that placenta, that it is a healthy placenta, that it hasn't become calcified from some indigestible supplement that she might have been taking that has landed in the placenta and not really benefited her in any other way. And if then the placenta has become calcified, again, we can be alerted to the fact that this placenta is not going to manage much longer maintaining a pregnancy. And so sometimes it is pertinent to induce a mum at some point, or to keep a close eye on her from week to week from that point, to see how quickly is this placenta calcifying. Maybe it isn't calcifying any further. Perhaps it is going to work just fine for the duration of the rest of the pregnancy. And so always when a midwife is working hand in glove with her team, with the obstetrician, with the ultrasonographer, and the osteopath or the chiropractor, all of these people coming together to not ensure, but to support a normal, healthy pregnancy. We want to see that the baby isn't completely tangled in the cord. Sometimes we can see that it's round the body all over the place. Sometimes if the cord is on the shoulder and you're going to see an aspect of the cord, it doesn't mean it's round the neck. It just means we can see it against the neck. And perhaps if we were to rescan in a week, we could see, no, that's moved now. And so she doesn't have a concern that she might have had when that was diagnosed.
And
So we
Sharon,
want to see the fluid still.
if a lot of it's a concern a lot of my moms land up having when they've gone for that 36-week scan, or even sometimes 34 weeks, and the obstetrician finds that the baby's cord is around its neck. At what point do we say that it's still okay, that because a lot of babies are born very successfully with the cord around their neck, and all the midwife needs to do is just slip the cord over the baby's head and everything works out beautifully. But at what point do our moms not need to panic that they spend the rest of their pregnancies in a panic about the cord being around baby's neck?
Well, that's a fabulous question because, of course, it depends on the length of the cord. If we consider how did generations cope before we had the scan, and they didn't know where the cord was or its involvement. If a cord is around any part of the baby's body, it can prevent them from descending into the birth canal. So the way that I work is I don't believe in rupturing the membranes at all. And so the baby remains in that atmosphere of constant pressure because of the amniotic fluid. And the amniotic fluid then is supporting the cord. So we can only truly diagnose a problem with the cord around the neck because the baby's not able to progress in the labor. It means the baby would remain high. There would be no pressure from the baby's head onto the cervix. So the cervix opens in two fashions. The baby is pushed by the power of the contractions onto the cervix from the top and applies themselves to the cervix and pushes the cervix open from the top. And the contractions are pulling the cervix open from the bottom. And so together we've got harmony. But if one factor is working and the other is not, then we have a dysfunctional labor. And when you have a midwife who is closely observing a labor, the wonderful thing about an independent midwife, I think, one of the wonderful things, is that we are there from the start of the labor throughout the labor. And we're not only looking at the shape of her body and how, because of a baby who is descending through the labor, we can see the shape of her body changing. We're also got our hands on that baby's body from the outside, and we can feel the changes. And then we're also listening with a sonic aid or an ultrasonic device. And we can see when we apply the sonic aid at the beginning of the pregnancy, where is the baby's shoulder? And we can just see from the outside of her body that that shoulder is descending, that where I'm picking up the fetal heart, it is descending. And then we're looking from the inside, we're doing internal examinations every 4 hours or so to see that there is progress being made. And because we are also medically trained, we work with a partogram, and that is a graph that shows progress in a labor. And that helps it, particularly if you're working in a team of midwives, or if you're having any kind of handover at the end of a shift, that we can see progress even though you haven't been with that mum right from the start of her labor. And what it shows us then is the dilatation of the cervix and the descent of the baby. And we need to see the two of those things working together to see progress. So if there is a short cord, or if the cord is preventing the baby from being born, then we will have slow progress or no progress. And sometimes that's the time to call for intervention, or at least in communication with the obstetrician to let them know that you are concerned about something. And either miracles happen, or that help is called for in good time, and the situation is handled medically. And sometimes, though, we're not sure what the delay might be. Clearly, we can't see where the cord is in the labor. We can't see if it's round the baby's neck. We can just see that this labor is not effective and there is a complication. When the complication is managed medically, most times, I would say 99.99% of the time, we can see, oh, that's why. It's never, we've called for a cesarean section and there was no reason for that. So when we are using the partogram and we're using our skills, then there's a lot goes into maintain. We can see when a labor is normal and nothing needs to be done here at all. We have wonderful progress, or that a labor is not normal, and therefore we call for support.
And Sharon, one of the things that we also look at in the third trimester is baby starts getting into position for labor. So at what point would we be concerned if a baby was still breech or facing posterior or even transverse? At what point do we start, being concerned, and what are some things that we could try to help baby get into a better position for birth?
Wonderful feed there, Danielle. So before I start on the optimal fetal position, I just wanted to say that I had a baby once with a cord 7 times around their body. I had to literally blah, 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 blah. The child was born in the water like a torpedo, like that, like that. No problem at all. Cord was like 1.5 meters long. So just because the cord is anywhere on a baby's body doesn't mean we're necessarily going to have a situation. It means that we need to be alert and aware and on the job more carefully and closely. But looking at the optimal fetal position, I start looking at that from 28 weeks, because we're looking to see which way up is the baby. And from 28 weeks, we want to see that they're starting to come head down. If they're not head down at 32 weeks, then I'm sending her for acupuncture, or I'm using homeopathy also is just going to help things to become normalized. That means, though, that if a baby is meant to be breech, and there are psychological reasons, and of course, we're looking at mother's psychological reasons and as well as the baby's soul journey reasons, that a baby needs to be breech. And you can do everything you like and do your Batman inversion thing, and still the child remains breech. There are reasons for that, and journaling really does help explore those. But if the baby's still breech 34 weeks, then we are working on things like taking the toilet roll, and getting the dad to talk into it, or particularly siblings can sing Twinkle Twinkle only down here at the pubic bone. We want the baby to pay attention and to come down and listen to these special people in their lives. We can use a little torch light, because it's showing a mum where the baby's back is and where the baby's feet are. Again, when the baby's awake and she's doing her kick charts to determine that, we can show her where to shine the light. So you're not shining it behind the baby's head. That doesn't do any good at all. You need to know the baby's awake, and you're shining the light in their face direction. And then you're tracking it down very slowly towards the pubic region. So the baby will follow the light and come down there. Also, if you are going to drop a drop of tea tree in front of the baby's face, they hate that. It's very strong for them, and they can suddenly think, whoo, I'm out of here, got to get down there. But of course, if the cord is involved and the baby can't rotate or can't get round, then it's a wonderful opportunity for her to see 28 weeks, 32 weeks, 34 weeks, 36 weeks. Then you had a scan, then we're looking, is there any reason that we can see while this baby's still breech? Is there anything that we can do to change it? And if not, then we've got the time to come to terms with the fact that this would mean an elective cesarean section, or the possibility of those wonderfully supportive obstetricians who would even be there to support a woman who chooses to go into labor anyway with a breech presentation and would choose to have an emergency cesarean section. It's not advised for first-time mums to have a vaginal birth with a breech presentation, because, of course, the biggest part of the child is coming last. It's different for a mum who's pushed a baby out before, because we know that she can get a 3.5 kilogram baby or a 4 kilogram baby out of her body. And so the biggest part coming last is not necessarily going to be the same concern. So she would have all of those opportunities then to explore her thoughts, her feelings, her choices around a complication like that. But if it's just that the baby is on the right hand side compared with the left hand side, this would mean that the baby's back is on the mother's right hand side. And that is not an optimal fetal position. It's where the boys tend to hang out, because that's your boy energy. Your male energy is your right hand side of your body. So they would need to have words with their mother about how they're going to navigate. We need boys to navigate like girls, because girls know how to navigate. Girls, if they get lost, will ask for assistance, help, direction. They will turn the map around and look at it properly to see which way should I be going. But boys who get lost just get loster and loster, and they never ask for help or which way should they be going. They just know they're right, and then they just get lost. The uterus has an interesting shape on the right hand side, which can also not prevent but encourage babies to remain on the right hand side. We also need to look at the pelvis to see, is the pelvis straight, is the symphysis pubis aligned, do we need to be clunked and clicked? We can't just label a pregnancy, a birth, as cephalopelvic disproportion, i.e. the head is too big for the pelvis, without looking at the condition of the pelvis, without looking at, there are things that we can do to lengthen ligaments on the right hand side and to give that baby an opportunity to roll round onto the left. And this means that when a baby starts from the left hand side, the girls most commonly, they get pushed into the pelvis by the power of the contractions, and they're rotated in an anterior direction. And that means that the back of the baby comes round into the front of the mother's belly, and we can tuck right down. You can imagine how the head then aligns with the mum's bum, and we have straightforward exit directions with few complications. But when we start on the right hand side and we have descent by the power of the contractions, then anything that is going through the pelvis gets rotated in a clockwise direction. And that means that the baby can very often end up in a posterior position. And this means that the baby's back is now against the mother's back. And that is the most painful labor ever created. That was the reason why the epidural was invented. And clearly, if she is in a posterior position herself, she's lying on a bed on her back, that is compounding it. And if then she's going to be given an epidural, that just means that we're now softening all the muscles that would have rotated the baby. And now we have flaccid muscles, and we have a compounded situation again, where she's on her back, the baby's on the back, she's not feeling anything, she can't get into a forward direction, she can't manipulate the baby, and the baby is pushed against flaccid muscles, which again compound the situation, and we're most likely to have a deep transverse arrest, which means that the baby then gets stuck in the pelvis and we end up having a cesarean section. So she again has autonomy over her body. If she has understanding, and of course, you know, there are those mums, you tell a mum the baby's on the right hand side and she goes into panic mode of, oh my goodness, that means instead of, I'm going to take this on board and I'm going to explore what can I do from 28 weeks to get this baby into another direction or a different position. And she will see that she has a relationship with her baby. She's doing kick charts from 28 weeks. She's aware when the baby's awake. She's aware when the baby's asleep. She knows that if she has a baby on the right-hand side and she lies on the right-hand side, is that what caused it? Is that what compounded the situation? Or does the baby think, oh my goodness, I'm getting squashed over here, and move to the left? If the baby's on the right-hand side and she lies on the left-hand side, does the baby then get dragged over to the left-hand side because of how she's lying? Or does the baby stay on the right-hand side? If she gets onto her hands and knees and she's doing her cat and her cow, her yoga positions, does the baby get swung around because the baby's in an ocean of amniotic fluid and the heaviest part of them then lies directly down the middle of her body like a baby in a hammock? Is that going to then offer the baby both directions? Now they can lie on this side, they can lie on that side. And she's playing the game then from 28 weeks. How's my baby lying? What can I do to ensure or to assist myself with my own labor and what lies ahead for me? How do I feel about an epidural? If I'm going to give birth in an environment where I am encouraged to be upright, first of all, and to shake my pelvis, i.e. to dance my way through my labor, isn't that going to be more beneficial than to lie on my back, even under the influence of pethidine, where I am all away with the fairies now, and unable to walk or dance or be upright and to participate in my labor? So positions in the labor, forward positions, encouraging a woman to be forward, is again why the pool is so attractive to women, because if you're getting into a pool of water, if that is your method of pain relief for labor, you're looking forward to a pool, not a bath, a pool, a birthing pool that has a mattress underneath the liner on the bottom for your knees to be comfortable. It takes 1,000 liters of water. You can go into the garden. It doesn't have to be a waste. Don't worry about the water restrictions coming up. That gives her buoyancy. She feels like a small elephant at the end of her pregnancy. And for her to get into that body of water where she's lifted and supported, for the midwife to bring a floating beanbag that she can lean on in her labor. Again, she's in a forward direction. She can push her feet against the side of the pool and rock and roll and move with her contractions, to breathe effectively, to bring oxygen to her baby in her labor, to have her endorphins flowing. That's her own morphine, it's her own pain relief that she's able to generate herself if she's given the right environment and the right support to do those things. It's far more powerful than any drug that we can give her, her own stuff that she makes herself. If she's got a partner who loves her and a midwife who's cheering her on and fabulous doulas who are supporting her all around her,
I love
then
this passion.
that's the way that her body is designed to work for labor. Imagine telling your grandmother, your grandmother who knew nothing. She had no Google machine. She had no books to read. She was just told in her youth that she's a woman, and at some point she's going to meet a man, she's going to make a baby, and then she's going to get this baby out of her body. Did she think, oh yes, I'm in labor now, I better lie on my back and stick my legs in the air because I've got to get a baby out of my body? We don't do that when we are expelling anything else from our bodies. We don't think, this is a good position, I have something to expel from my body, I'm going to lie on my back and stick my legs in the air and expel this successfully.
Sharon, you are fantastic. I love you crept right into labor, birth. I love it. I love it. So we unfortunately heading at the top of the hour. And so we're going to round up now. But this is still, we've still got so much to explore in the third trimester. So we're definitely coming back next week to do more in the third trimester and then move on to labor and birth. But Sharon, that was beautiful. I was there. I was in the birthing pool. I was doing it. I felt it. I knew it. So thank you. Just a quick one. Danielle, what would you say? Your parents have gone into the third trimester. What's the first thing you say to them?
Oh, just to enjoy those last few weeks. You know, that's often when a lot of the aches and pains start creeping in. You know, the heartburn and the backache and the swollen ankles. And just to keep remembering what is actually happening inside your body, you know, that it's not just this illness, you know, the aches and the pains and the hurt and the, it's that it's your whole body is creating this being, this whole universe. And that's my biggest thing, is just to keep focusing on what your body is actually achieving. And to, you know, when that heartburn creeps in, just to know that it's all for this baby. That's what I tell my mommies.
Sharon, what's the number one thing you say to the third trimester mummies?
Well, all that heartburn and all that backache and all those swollen feet, completely avoidable if you do a raw diet for 36 weeks. And also for them to be aware that, you know, we've got more access to information in this generation than any other generation gone before. And yet we have a higher level of postnatal depression. And 1 in 4 women can expect some level of postnatal depression in this modern world. And yet 1 in 3 men has a level of postnatal depression. And why is that? And it's because women prepare, they are forced to prepare. They've got a person growing within them, you can't forget it for 5 minutes. And men don't tend to prepare in the same way. And so we do need to talk to people as couples, as families, and prepare all members, not just the grown-ups, but the children as well, for the change that is coming their way.
I'm with you 100%. And my number one thing is always educate yourself. Be prepared.
And that's both sides of a point, of course. It's not just blind yourself to, I don't want to look at any bad things that might happen.
Yes.
I need to inform myself and make
Inform
informed
yourself.
choices. Yeah.
And have a doula and a midwife, because that's how you're going to get your magic birth and your calm, beautiful birthday. Ladies, as always, an absolute treat. And I look forward to next week. We'll carry on with the 3rd trimester, and we'll go back to the beginning again. And I just loved today's session. I loved that last bit, Sharon. I'm reeling on it still. I loved the whole, I was in that birth bath, that bath. I loved it. So thank you, ladies, and we'll see you next week.
Thank you.
Bye.
Bye.